Part B covers a systematic approach to CPR decision-making. It begins with a medical assessment and a medical decision. It identifies 4 clinical categories, each with its own discussion aim, and it incorporates the individual patient's values and what is important to them.
Dr. Barbara Hayes, you've completed your PhD in decision-making around CPR, because as a clinician you noted there was a lot of inconsistencies and differences to other decisions. Why is CPR decision-making different to other decisions?
I think it is a little different because of people's expectations. The patients and their families often think CPR is standard treatment and should always be given. And also we teach CPR as first aid treatment in the community for everybody who has a cardiac arrest. So we've created a very high expectation that CPR will always be provided, and so we need to often raise this even if we're not going to provide CPR.
Is it a life and death decision? Is that how we should frame it up with our patients?
I think CPR does seem to be very much a life and death decision. You can't discuss CPR without discussing life and death. You can have discussion about other treatments without discussing death, but not CPR. So it's a high stakes decision, and the potential for it to result in perhaps a life that is even worse than death is often not considered by the patient and family. The stakes are high and trust becomes important.
So it's really no surprise we've got a high stakes discussion with patients with a high expectation of a good outcome, and we know it's going to be poor. But for some patients, CPR being the default position is appropriate and on those who it was designed for. Can you tell me about that group?
Well, in hospitals, of course, unless there's an order not to provide CPR, we provide CPR. Now, for many patients that will be appropriate, particularly young people with just an acute illness but not a lot of comorbidities, patients who've had acute myocardial infarct or acute cardiac ischemia have some very successful outcomes from CPR being monitored. They're already being monitored in coronary care. If they have ventricular fibrillation, they may have up to a 60% chance of survival. This is what CPR was designed for. I guess the other group would be people having surgical procedures, having anaesthesia with their functions being taken over by an anaesthetist already.